The appendix frequently shifts from the right lower quadrant, hiding behind the cecum or dropping into the pelvic cavity. Clinicians test rebound tenderness by applying steady pressure, but the finding happens on the release. When you let go, the tissue's snapback irritates the inflammation. If the appendix is buried deep within the pelvis or behind the colon, this surface-level pushing will completely miss the inflammation. We have to use dynamic mechanical maneuvers to provoke it. The Rovsing sign uses a mechanical proxy. Pressing deeply into the left lower quadrant displaces internal volume. This shift stretches the continuous peritoneal lining spanning the abdomen. That tension travels across the cavity, pulling on the inflamed appendix and triggering localized pain strictly on the right. By using the peritoneal lining as a pulley system, you confirm right-sided irritation without ever pressing directly on the infected site. For a retrocequal appendix, we use the psoas sign. The patient lies on their left side. The examiner extends the right thigh backward. This motion flexes the internal psoas muscle. That tightened muscle rubs directly against the inflamed tissue, causing pain. For a pelvic appendix, we use the obturator sign. The patient lies flat. You flex the right knee and push the lower leg outward, rotating the femur inward. This contracts the obturator internus muscle deep inside the pelvis, striking the low-sitting appendix. These maneuvers map the internal anatomy by using the patient's own muscular geometry to squeeze a reaction out of a deep-seated infection. When evaluating children, the physical baseline changes. Adult symptoms like abdominal wall rigidity do not reliably present in pediatric patients. This chart shows the positive likelihood ratios of various clinical signs. You can see that for children, the obturator and Rovsing signs carry a high 3.5 ratio. These dynamic maneuvers, along with the Dunphy sign, where pain is triggered by simply having the child hop or cough, provide the most accurate physical data for ruling in pediatric appendicitis. Let's test this anatomy in practice. If a patient lies supine and you flex their right knee while pulling the ankle outward to rotate the hip, which specific sign are you testing, and where is the appendix positioned? That is the obturator sign, which isolates a pelvic appendix. However, these individual physical tests are pieces of a larger equation. We compile these findings into the Alvarado score. This clinical decision tool assigns 2 points for right iliac fossa tenderness, 1 for rebound pain, and 1 for fever. It then adds those physical findings to patient history and lab results, like a high white blood cell count, to stratify surgical risk. Rebound, Rovsing, psoas, and obturator form a complete physical assessment protocol. Mastering these specific maneuvers allows you to systematically gather interlocking data points. You calculate definitive surgical risk and leave the appendix nowhere to hide.